so much. Okay, great. So pain, generally, what we understand of pain is that pain is just when something hurts. Okay, that's our understanding of pain. But then there are, can you hear me?
Yes, miss. Instead of clicking got it, I clicked leave meeting by accident. Sorry, I'm back now.
That's totally fine. So, okay, okay. So looking at pain, what we understand from pain is that pain basically means when something hurts, right? So when you, that's the basic definition that we know of it. However, how does something start hurting and what is affected that something start hurting is everything that you will be looking at under pain. So the types of pain and how pain travels in your body, how pain starts, initiates, origins in your body, all of that will be covered under this. And generally, pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Okay, that's basic definition for pain. And we basically know that when we're talking about pain, everybody has a different emotional experience to it, everybody has different sensations of pain. So while something like, for example, using the example of piercings, okay, so for some people piercings might not hurt, they might even have an addiction of getting everything pierced. However, for other people they cannot bear the pain of a piercing. So there are differentiations with every single person on how they will perceive pain, how they will deal with pain. So we will get to the theories of pain, but let me just see where's. So the thing is that you when you're looking at the book, so the first thing that you get over here is definitions of pain. However, they've already started with the theory, so we're just going to do theories first and then come back to the definitions because it's way easier to understand that way. So when we're looking at theory, so we looking at Melzack's concept of pain, right? And then we're also looking at Descartes, we're also looking at specificity theory. So both of those again are important. So generally explaining this to you, not a part of the book, but when we look at Melzack's theory of pain, okay, which is basically the gauge control theory, what you need to understand is four different things. So the first one that you need to understand is, now this is something that I would like you to look at. So I'm just going to share my WhatsApp screen. I'm going to send it to myself and I'm going to share the WhatsApp screen so it's easier for you to view what I'm trying to explain here. So you'll have to wait just a minute. I am sorry for any delays.
It's fine, miss. Take your time.
Thanks so much. Okay, so Melzack's concept of pain, before we get into the types or the other theories of pain, we need to understand the basic definition and how it actually implements in all of these theories. So the four aspects that we need to know, the four aspects of pain actually that we need to know is, the first one is nociception, okay. So that is basically the sensory process that provides the signals that lead to pain. This occurs through nociceptors that are primary sensory neurons that are activated by stimuli that cause tissue damage, which includes tissue injury, extremes of heat, and noxious chemicals, right? So they basically are telling that when you talk about nociception is basically your sensations. Okay, so there's a difference between feeling something and then having a sensation. So when you're feeling something, that is very palpable. When you're having a sensation, that's very physiological, that's within your body. So they are telling that every single time that you undergo pain, you have to go through this nociceptions where basically your nociceptors, which is basically your neurons within your senses. Okay, so your senses of sight, touch, smell, taste, all of these senses have certain sets of nociceptors, basically certain sets of neurons that are activated whenever these senses are activated. So every single time that something hurts or something, there's an unpleasant sensory feeling, that will activate all of your senses. Okay, so you need to be aware that you, whenever, every single time you have a tissue damage or an injury which leads to pain, the first thing that will happen is that all of your sensory neurons will actually be activated because of this concept of nociception. And this concept of nociception just states, it basically involves all of the sensory neurons that are present in your body, and it basically involves how these are working with pain. Okay, that's the first thing. That these are all the things that will matter when you are undergoing pain. So the first thing that will matter is that all of your senses will be activated. The second thing that will matter is the perception of pain. Okay, so your perception of pain, how much it hurts, how are you viewing this pain. So there are people who literally disregard it and say it's nothing. However, there are people who are also over dramatic, overthinkers, so again, your perception of pain is another thing that will matter. The third thing that will matter is the suffering. So how much fear, how much stress, how much pain actually is this thing getting for you. Okay, is this thing implementing on you. And then last thing is pain behaviors, that how once you have the nociception where your sensors are activated, and once you have your perception of pain, and once you have your suffering, how do you react to it, what is your behavior, what is your response towards it. Now those are the four basic stages of a person undergoing pain. Okay, that was Melzack's concept of pain, which will eventually help you understand gauge control theory. Okay, so again, when we're looking at the drawbacks of pain, the one, this is also in the first part of the book. Okay, so three useful, the first thing that says in the book is the three useful functions of pain. So basically it provides protection because a person is always conscious, and again it aids learning because again you are cautious, conscious, sorry, I said conscious, I meant cautious, because you avoid harmful situations. And then the third one is also that it will limit your activity. So you just try to remain tender, try to remain a little relaxed, try to remain a little cautious again. That will actually help with your bones and activity, your muscles and everything. Is that clear till now?
Yes, miss.
Okay, moving ahead and looking at the theories of pain. So first one is specificity theory, done by Descartes. So basically there was, you don't need to look at the first point. Okay, um, we basically start from the fourth point. Okay, so this theory is actually, it's okay, we'll look at the whole thing. So Juan Frey was basically a psychologist who suggested that the body has a separate sensory system for perceiving pain. So basically the body generally has different sensory systems for everything. Okay, so if you for every of each of your senses basically, so it has a separate system for your hearing, separate system for your vision. So your separate system of your vision basically means that everything to do with your sight basically is connected to a whole other there's a whole other pathway of it. Similarly, everything to do with your hearing has a whole other pathway. Similarly, one phrase said that everything to do with perceiving pain, how you are taking pain or how much it is hurting, also has a separate pathway. So they say that it holds that specific, now this separate pathway, okay, the separate sensory system, they're saying that it holds pain receptors, transmit signal to a pain center in the brain that produces the perception of pain. So basically they're saying every single time it hurts somewhere, okay, every single time you are injured or you have tissue damage, what happens is that your senses for pain, okay, the separate senses for pain, the separate sensory system for pain, that is basically in your body is activated. And as soon as this is activated, there is a signal sent to the brain, which is called the pain center, and this basically decides your perception of pain. So like every single time you look at something, this the sight that you're looking at travels through your body, travels through your sensory system, and then reaches the brain where you get where you have this understanding that what you're looking at. Similarly, when every single time it hurts somewhere, or the senses, that every single thing that is activated travels to the pain center, which is the brain, and then this pain center decides how you are having, how you are going to perceive this pain. Why is it called specificity? Because they're saying that there are specific pain receptors. Receptors is basically responders, okay, the neurons that respond to the pain. So they're saying that there is a specific whole process of how you're going to perceive pain. And now they're saying the more this pathway is used, the more intense is the pain experienced by the person. So let's say if you burn something, if you burn your finger, so this, the level of pain that you will suffer, first of all, will travel through your pathway and it will reach the pain center, where you will be like, okay, it hurts a lot, now you have a pain perception. But with burning sensations, it's like it keeps, occurring again and again. It activates again and again, again and again, again and again. So that means as much as it will be activated, that means that is the amount of times that the receptors will travel through this pathway, through this specific pathway. And that will lead to your brain experience, your brain's telling you that yes, you are experiencing more and more and more pain. So this is the thing, that the more the pathway is used, the more that it starts hurting. So this theory considers pain as an independent sensation with specialized peripheral sensory receptors, which respond to damage and send signal through pathways in the nervous system to target the centers of the brain. So again, it is just saying that you have a specific sensory system for pain, where these sensory receptors travel, and then they travel through your veins and travel through your nerves, and then go to the brain, where it decides how you are perceiving pain. And these sensory receptors are called nociceptors. Okay, peripheral sensory receptors. Receptors are basically responders to pain. So whenever a noxious event stimulates a pain receptor, noxious event is like an injury basically. Stimulates is when it activates a pain receptor. So this pain receptor sends a signal to the pain center, and this is in the brain. And then when the pain center is informed, then you basically know how to perceive pain. Is that clear?
Yes, miss.
Okay, another thing you need to know, which will help you with the evaluation of this, is that according to this theory, pain is purely physiological, as in purely biological. Okay, there is nothing psychological about pain. It is everything to do with your body, everything to do with your neurons, everything to do with your brain structure, and so on. Okay, it's saying that there's nothing psychological with this. So I'm not gonna I have this thing that I don't do evaluations right away. I explain everything first, and then at the end of a certain subtopic, then we'll go back to evaluations. Because I always prefer the student doing evaluations rather than me explaining evaluations, because they are pretty said. The only way to know how to evaluate a certain thing is by evaluate, like when you're sitting in an exam, you will only remember if you have done it yourself before. That is why every single topic I would like the student to evaluate and ask me if their evaluation is right or wrong when I am reviewing it at the end of the subtopic. Okay, so that's why I'm going to skip through evaluation for now only. Coming to the second theory of pain. Okay, so the second theory is called gate control theory. Again, Melzack and Wall basically propose this idea of gate control theory. So this one also takes a step forward. The specificity, it says that yes, this is true. Whatever specificity theory is saying, that is absolutely right. However, we want to take a step forward, and we also want to experience something that is psychological in this. Okay, so they suggest that a pain is a combination of sensory experience and psychological gates that can increase or decrease the perception of pain. So while we are saying that yes, according to the specificity theory, this is how we physiologically feel when we are in pain. Okay, so this is something that yes, we understand that yes, pain can you can have a perception of pain based on the sensory experience of pain. However, they're saying that there's also a psychological concept which is called the gate control theory itself. So pain is detected and picked up by sensory signals, but the spinal cord plays a key role in the experience of actual pain. Now that's the one theory that the gate control is presenting. The spinal cord has a mechanism that it acts like a gate. It either opens or closes. The theory suggests that nerve impulses which produce pain pass through a series of gates on their way up to the brain. And these gates are influenced by messages descending from the brain and by other information that we are receiving. Okay, so they are saying that while you are saying that you are absolutely right, they're telling Descartes that yes, you are right, that pain does travel, and it travels through the sensory pathway. However, it is upon the spinal cord that whether it will let pain travel or not. So the spinal cord, they're saying, has gates which can close and open, and they are saying that this closing and opening of these gates depends upon what we are thinking. So it is psychological. It is nothing to do with your physiological process. Your physiological process is where your pain is traveling and everything. However, when it comes to these gates, this opening and closing of these gates, this is to do with your your psychological thinking. Okay, so the spinal cord might decide not to open its gates. Okay, but why? Okay, it might just stop the pain from traveling, but why? Okay, so that is what they're discussing over here. So if it opens, the pain is experienced, but the spinal cord can modulate the pain level by having the gate slightly open rather than fully open. According to this theory, the gate can sometimes be overwhelmed by a large number of small activated fibers. In other words, the greater the level of pain stimulation, the less adequate the gate in blocking the communication of this information. So they're saying if it pains a lot, you won't be able to stop the gates from opening. They will eventually open. So if someone literally bursts their head into a tree, there is no way that you're stopping the gates. It will hurt no matter what. There are three factors which influence opening and closing of the gate. So the amount of activity in the pain fibers. So how much pain fibers is basically, let's just say that pain is connected by small fibers. Like when we are making like a thermopole is connected with small balls of thermopole, small balls of cotton, right? So similarly, pain fibers is every small fibers which create that pain. Okay, so they're saying if that there's a lot of pain basically, that means that yes, the pain that they eventually the gate will open. That's one thing. The second thing is the amount of activity in the peripheral fibers. So that is those fibers that carry information about harmless stimuli or mild irritation, such as touching, rubbing, or lightly scratching the skin. These are large diameter fibers called A beta fibers. Activity in A beta fibers tends to close the gate, inhibiting the perception of pain when noxious stimulation exists. This would explain why gently massaging or apply. So basically, there are these A beta fibers are basically to do with the activity, soothing activity. Every soothing activity is affects your A beta fibers. So if you activate your A beta fibers, that would mean that your pain would the gates would actually close. So let's say if you start massaging a place, or if you start putting pressure on a place, or if you start soothing a place in some sense or the other, that will mean that the pain will reduce. Hence, the gates will close. So you need to activate your A beta fibers, which is basically your soothing fibers. Okay, and then the third thing and the more important thing over here, it is also depends on the messages from the brain. So basically, they're saying messages that descend from the brain, neurons in the brain stem and cortex have different pathways to the spinal cord, and the impulses they send can open and close the gate. So what you're thinking, in your head, in your brain, so your brain can help you decide whether or not you want the gates open or closed. Okay, so something environmental that is affecting you, let's say you are in front of a lot of people, so you would not want to start crying at that point. Hence, in your brain you will be like, I'm in front of a lot of people, I don't want to embarrass myself. And that message from your brain to your body will actually prevent from the gates from opening, and thus you will experience lesser pain, at least in that moment. So that is another thing which can stop the pain from actually traveling. Okay, do you understand these three things? I know it's a little complicated.
Yeah, miss, I get it.
Okay, that's great. You don't need to know the last thing. That's a reference study by Sarafino. That's pretty much it when we talk about the gauge control and the specificity theory. Coming back to the types of pain. Now, what in the book, it's very confusing in the sense what they've done is that they've talked about acute and chronic organic pain, and then they have given the theories, and then they have jumped back to psychogenic pain, and then they have also included phantom limb, even though phantom limb is a totally different type. So that confuses the chapter and the content a little bit. However, it's fine. We're just gonna follow this handout that I have got. Just a second. I'm just sending more pictures. Okay. Okay. so now we have the types of pain. Okay, so looking at the first type of pain, which is acute pain. Acute pain is like short term but very intense pain. Okay, so something sharp when it cuts. Okay, so or getting stung by a bee, all of that will be, or burning your hand, is every single thing that is acute pain, even though it is short term. But it can be healed. However, it will hurt a lot while it's there. Okay, so that's basically acute pain. When you're talking about chronic pain, it is basically a long term pain, and it is something that generally affects your muscles in such a way that it will all it tends to follow you throughout your life. Arthritis is a very valid example of this. One thing that always complicates over here, whether headaches are chronic pain or acute pain. Headaches are acute pain, however migraines are chronic pain. So there's a difference between the two of those. So when you're talking about chronic pain, it also interferes with your normal functioning. So if you have arthritis, you might not be able to walk properly, or if you have some sort of limb pain, that also might not help you to work out, to sleep properly, all of these things. So these chronic pain lead, because they are long term, and then because they're long term and severe, they might just have a lot of effect on you. They can have a lot of toll on you, a huge toll on you. So again, diabetes, they've given an example of arthritis over here. Diabetes is another one. Looking at organic pain, so it is discomfort. So this is not a part of the thing, so you don't need to know it. Psychogenic pain is basically, it refers to episodes where there is no organic cause of pain, but the person is experiencing pain. So that's physiological. There's no physiological cause, but there's still pain. So it is a type of pain that is caused, increased, or prolonged by mental, emotional, behavioral factors such as headache, stomach pain, back pain, etc. So now, why does it say psychogenic? Because it is not caused by something physical that happened to you. However, psychologically you think that this certain part is hurting. So it is pain that is to, there is no physiological evidence of it, however it still hurts, right? So if you say that something burned, now that has a physiological evidence to it. However, if you say my back hurts, now you can't really, nobody can actually look inside your back, like cut it, look at the spinal cord, okay, why is it hurting? So that will come under psychogenic pain. It is to do with your psychological condition, that you feel like, okay, something is hurting. So it's more towards your thought processes rather than having a physiological evidence to it, or having a physiological reason towards this sort of a pain. Looking at phantom limb pain. So phantom limb pain is that you basically, when a patient is an amputee, okay, and he basically still feels pain and in areas where there's no limb. So right, have you watched Forrest Gump?
No.
Okay, you should. That's one thing. However, it's okay if you haven't. Phantom limb pain is basically, let's say, there are a lot of people from the war who never, lose their hand, or they something like that. So they basically are an amputee where they do not have a certain part of their body. However, even though that has healed, or even in the birth conditions, there are a lot of people who do not have one feet or one hand or one arm, something like that. They're all amputees. However, that part still hurts a little bit, even if it has healed. So that is a phantom limb pain, that it causes some sort of an electric shock inside your body, and it causes your sensory system to be activated, that eventually leads to your phantom limb pain, that you're, even though it has happened, you have gone through that condition, it has been a lot of years, it has healed, but there's still some sort of a cramp or something over there. Claire?
Yes.
Okay, looking at measuring pain. So again, every single thing needs a measure. So you measure every single thing in a certain way. So similarly for measuring pain, you've got a few series of self-reports only, mostly. So the first basic one, which they have mentioned in the book as commas, over here they've given a little bit of detail to that. So self-report measures are one way to measure pain, that you take a questionnaire or you take a survey, and or an interview, and then you get how much it hurts. Okay, so they say that the visual analog scale is one way. So visual analog scale is that you basically are given maybe 100-meter line, millimeter line, and then you're told that just circle whichever ones uh, whichever is your scale of hurt or pain. Okay, so from 0 to 100, whichever one, however much it's hurting. So it's, why is it called visual analog? Because it's visually obvious to you. You're looking at a scale. Okay, so they've said it has a 100-meter line with descriptors ranging from no pain, moderate, to, like over here they've given us pain and worst possible pain. So this is something that would be a visual analog scale. They have given a line, and then they have given definitions to that line. I think there's a Wong Baker scale looking exactly like this. Then we have the box scale. Again, that is similar. However, it has box which has numbers. Verbal rating scale is that you basically choose from the verbal options that have been given to you. So no pain, some pain, considerable pain, worst pain possible. Likert is basically agrees, disagrees, stronger. So there's basically 5 to 7 responses. It's like a multiple choice. Again, you don't need to get into the detail of these. You just need to know. Pain diary is when you record data, like when you have a dear diary. Similarly, you have a pain diary and you record data and something like this. How much it hurt on a Tuesday, how much it hurt on a Wednesday. Clinical interview is that again you have an interview, you have a dialogue, you have a conversation with a psychologist, and they ask you preset questions, they ask you follow-up questions that will eventually help them understand how much it might be hurting you, how much a certain thing might be hurting you. Now these are very generalized measures, these are very general. Then we have some specific ones as well. So they have been mentioned in the book. Clinical interview has also been mentioned. Clinical interview always helps you understand more in the sense that you can understand the duration, you can understand the intensity, you can understand the quality, you can understand how often, because you can ask questions very directly. So that all of that might not be very possible to include in a questionnaire, but when you are asking a person, when you're having a normal conversation, it is way more easier to attain all of this information in a very casual manner. Is that clear? Is this clear?
Yeah.
Okay, so this was general. Again, you have specific ones. So that includes McGill, that includes Wong Baker. We're just going to get into this. So first one we've got over here is McGill pain questionnaire, right? So basically it was a pain rating index, PRI, and wait, sex psychometric. Yeah, okay. Okay, so this is basically under psychometric measures and visual rating scales in your book. So one standard psychometric measure of pain is McGill Pain Questionnaire proposed by Melzack. Patients are asked to tick the word in each class that best describes their pain. Based on this, a pain rating index is calculated. In addition, patients are asked to indicate the location of the pain on a body chart. So again, they are asked how where where it is basically hurting them, and second, they have to tell the location as well, and basically whatever best describes their pain, like however much it is hurting them. To compile the objectives for the self-report, the Melzack used a sample of doctors and university graduates to classify objectives into groups describing. So basically, how did he describe these? How did he get these three different groups? That's what they're explaining. That he had a long-term discussions, and that then he led to these three groups of pain. So the first one was sensory. So how is it feeling physically? Okay. The second one was affective. How is it feeling emotionally? And evaluative. How is the overall intensity of pain? Okay. So in effect, sensory, it would be that is it burning? Is it electrically shocking you? Is it throbbing? Is it tingling? Is it tickling? Affective would be, is it worrying you? Is it frightening you? Is it making you anxious? Okay. Evaluative would be generally psychologically and physiologically mixed. How is it feeling? Is it unbearable physically and psychologically? Is it worrisome physically and psychologically? So that was the three ways that he asked them to describe the pain. uh, the questionnaire consists of 4 parts. The first part was that a diagram of the body is presented to the patient, who simply has to mark where the pain is located around the body. So again, this diagram, as you can see, this is the first part. Like it says, part one over here, you just have to say where the pain is. Okay, so people might not even might not be able to explain it well enough either. So they have given a whole a chart of the body for the person to clearly state where it is actually hurting them. So that is one thing. That's the first step. Then the second step is there are 20 subclasses of descriptive words from which the patient has to choose a maximum of one per class. The further down the list in each subclass the word is, the more the points it scores. So that an index. So basically, before I read the whole thing, let's say they have developed these classes, and within these classes what they have done is that you have to choose at least one out of four, no sorry, at least four, I believe. So maximum of one per class, yes. So maximum of one per class. So they have at least 20 classes, and you have to choose maximum of one per class in order to make your intensity of your pain understandable. And they're also saying that the further down the list in each subclass the word is, the more points it scores. So if it is, let's say, if it is over here, if it's throbbing, that means it's a lot. If it's the last one, if it's pounding, that means it's unimaginable. So the more down the word is on that list, the more it is basically hurting. um okay, moving ahead. the third part is that the patient has to describe the pattern of pain from the three subclasses of words and then produce some qualitative data about what things relieve or but also increase the pain. So three subclasses is basically affective, evaluative, and sensory. You have to rate the pain on those basis qualitatively, and then you also have to describe how you actually stop the pain, how does it increase, how do you decrease as everything included in that part of it. That's the third step that you have to present over here. And then moving ahead, the last part is the final part, asks you to ask the patient to rate the strength of the pain via 6 questions. So the scores of these questions are added up to create the PRI, so pain intensity score. So just a second. So that this is the last part over here. So these 6 questions, you have to answer them like a questionnaire. That's it. Do you understand?
Yes, miss.
Amazing. Psychological or medical measures of pain. So again, the one we were studying were all related to more evaluative. Okay, now we're just looking at psychological or medical. So that includes physiological and medical. Sorry. So basically, we were looking at psychological measures to do with the brain. Now we're looking with to do with biology. So the first one that we've got here is an EMG. So you basically record eye movements. You basically record movements within your muscles. EEG, again, eye movements, brain activity. You record brain activity. So as soon as your EEG shows EEG, do you know what an EEG is?
An EEG?
Yeah, it's like an electroencephalograph.
Yes, they use it to check like the brainwaves during sleep as well, right? I don't know the full form. I know it, but I can't pronounce it. Electro something gram.
Yeah, yeah, that electroencephalograph, something like that. I don't know it myself either. It's so difficult. But yeah, so you basically know what it is. So that is to measure physiologically how your brain activity, your sensations. The movements in the EEG basically show how much it is affecting you, how much it is affecting your senses. So that is one way of checking physiologically how much a certain thing, how much it is hurting. Um, that's physiological measures. Moving ahead, we have behavioral or observational measures, so that includes the UAB scale. Now behavior and observational basically means that you do not need the person to tell them yourself, you do not need a self report, but you can observe their behavior and get it. So in this UAB scale, the nurse was basically observing behavior, and that actually led her to understand. So behaviors believe that we should not investigate subjective feelings, etc., etc. So according to Turk, these characteristics of pain behavior that we display are facial expression. So your facial expression can tell how much it is hurting. Distorted posture can tell how much it is hurting. Negative effect, which means that generally if you're in a bad mood, if you're frustrated, that will also explain. And avoidance of activity, if you're avoiding a certain thing, like if you're avoiding going out and everything, that all of that will be included in behaviorally studying a person, observing a person, and understanding that it hurts. So Richards actually had this UAB scale in which the nurse basically studied the person and their behavior in order to know more about their pain. So in addition, structured clinical sessions can be used. So again, when they're telling all the ways you can observe a person's behavior. Now within that, the one example is UAB behavior scale, which can be used to track the severity of chronic pain over time. This can help determine the level of pain control and identify temporal associations that influence management. There are 10 types of question, and each item is scored on a 3-point scale, 0, 0.5, and 1. The higher the score, the more marked the pain associated with the behavior. So basically, in chronic pain over time, it's mostly for adults. Okay, so when they have chronic pain, there's a nurse always. It is a professional nurse. It's always observing them or observing them doing certain tasks, like for example, sitting, standing up, tying the shoelaces, picking something up from the ground, picking something up from the top of a shelf, all of these behaviors. And she basically uses these 10 questions in order to rate them, and then see however how much it is still hurting them based on their behavior, so based on the observation that a professional nurse will be making. Is that clear?
Yeah.
Okay, now we have how to measure pain with children. So obviously all of this was for adults and it is easier for them to understand. However, when we talk about children, they obviously need to, they cannot explain their pain as well as adults can, and hence they have separate measures. So for that, the first one that we have is P. PPQ, so that's pain pediatric questionnaire or pediatric pain questionnaire, okay. And then we have Wong Baker scale. So when we are talking about PPQ, so that is basically that was created by Winey and Thompson, and it is a multi-dimensional questionnaire. So basically, it is assessing more than one thing at once, okay. So it assesses the perception of patient's pain experience in a child-friendly format. It measures the pain intensity, location, and sensory evaluative and affective qualities of pain. So it's basically measuring every single thing. That's why it's called multidimensional. The PPQ allows a comprehensive assessment of pain in children with chronic pain. Children have to describe their pain in their own words. Then, to help them describe their pain some more, they choose to as many adjectives as they want to. So just a second, there is a visual analog scale used with faces as the bipolar ends, and then similar to the MPQ, a picture of a person so they can indicate where the pain is. So one thing that they're asked to do is that they are basically asked to describe their pain, and within that they are helped by the professionals that they have to state a certain thing, and then adjectives are used, and all of that basically helps them evaluate the level of pain, the intensity of pain. And they're saying that there is a visual analog scale, like to what extent is it happening, how happy, sad, okay, happy to sad, you have to. So it's visually pleasing, visually formatted in a such a way that it is easier for children to understand. Moving ahead, they also have a picture of the person so they can actually circle which part is hurting. That's another thing that they are likely to do when they are in the second part of it, and likely to do in the sense that it is easier for them to understand. And then the last part is, in addition to choosing the faces, the children get to pick colors and then color the box. So in the sense that they can color how much it is hurting and not. So basically you can look at this in the book. Okay, so not hurting, no discomfort, pain, to hurting a lot, very uncomfortable. So they have to circle from the adjectives that they have been given. Once they are explaining, how if they can't explain, that they have to use this glossary that has been given to them, and then they have to circle, and they are explain these words that they are about to circle. Then they are basically given the visual analog scale, they are given the photograph to tell the location, and when they're given this visual analog scale, they are given the option to pick up a color and color these boxes of happy to sad. Okay, is this clear?
Yeah.
Similar to this, we have a Wong Baker scale. Again, this is also for children aged 3 and older. So they basically have visually they're shown smiley faces too. Till number 10, so it's 0, 2, 4, 6, 8, 10. So phase 0 basically means that it doesn't hurt. Phase 10 means that it hurts so much that they can't stop crying, and it feels really bad. Maybe phase 6 means that it hurts even more, hurts a little, something like that. So the Wong Baker scale is again a visual analog scale, which is helping you understand how much a certain thing is hurting from a scale of 0 to 10. For it is mostly for children, and it is also mostly for categories of acute pain um, rather than chronic pain. Okay, is this clear till now?
Yeah.
Okay, I am going to stop screen sharing. The next part is something that we're going to be doing from the book. So looking at managing pain. So again, now you know what happens pain, how pain is perceived and how it travels, and then you know how to measure pain. Now you need to know how to manage or control pain, right? So how to stop pain. So if something is hurting, how to stop it. Just give me a second. Okay, yeah. So the first way to manage or control pain is through medical techniques. Now, medical techniques can be divided into two different sectors. So the first one is surgical treatments, where you have surgeries, where you have operations. And then the second one is biochemical. So that's more to do with pills, that's more to do with testing, that's more to do with injections. So they're saying that surgical treatments are used when medication doesn't relieve pain. Such treatments can consist of cutting nerves pathways or making lesions in special centers of the brain. It is usually for people who have terminal illnesses. There are also several physical therapies that are used to ease and manage pain. So most people, after they've had a surgery, they actually go into therapy in order to accept the fact that they have been through such a hard time in their lives. Okay, so that's what they're trying to explain here. Biochemical is a another way to relieve pain. So that's to do with painkillers. That's to do with um, analgesia. So that is basically analgesic drugs which makes basically make you numb, make your nerves numb. Hence, when you are numb, so you can't feel anything. So that's basically drug treatments for pain associated with inflammation. So that's again when something is swelling, such as back pain or headaches, or paracetamol or anti-inflammatory painkillers work best. So they've given us examples over here. Otherwise, even with depression and everything, you have tablets and pills that work. Then you have chemical treatment for pain, aspirin and Panadol and ibuprofen, all of these. Okay. So they're saying that these help to these generally help with fever, generally help with short term pain illnesses, or like not chronic but generally acute pain. um, Even with gastric pain. Okay, so that's something that you could take Rizek for, or anything such, Gaviscon, whatever. Then you have other drugs include paracetamol or opiates. Opiates inhibit pain messages from traveling to the brain. Inhibits means stops. Okay, it prevents pain messages to go in the brain, like it makes pain just stop there, makes it numb. Morphine. Okay, morphine is used in order to just make yourself numb. So they're just giving general examples. You need to know these examples. You might be asked to give some of these examples and explain them and how and why they're used. So this is one thing, that's biochemical treatments. Do you understand that?
Yeah.
Okay, and these are just remember to focus on the part that these are more towards physiologically controlling pain or physiologically managing pain. However, when we're talking about psychological techniques, that's to do more with the brain, that's to do more with the cognitive part of it. So they, again, therapy could be one, so but then there's relaxation techniques, there biofeedback, there's hypnosis, then there's counseling, there's mental imaging, there's a lot of techniques, relaxation techniques. So the first one that they've given us is attention diversion, non-pain imagery, and cognitive redefinition. Cognitive redefinition is where an individual attempts to alter their thinking to replace thought of apprehension about pain with other more positive thoughts. This cognitive approach is related to distraction therapies and involves patient replacing thoughts such as this is really going to hurt with this is not the worst pain. So basically being more, I would say, to have alternating and more strong acceptances and redefinitions for your pain. So this is done through therapy, where if something hurts, you tell yourself that this is not the worst. You are stronger than this. Just having the self confidence, or developing the self confidence of being able to undergo a certain thing physiologically and cognitively. That is what you do with cognitive redefinition, that you cognitively redefine yourself in such a way that you are presume yourself to be a person who is strong, and a person who can undergo this without having to go through a very difficult time. Okay. Attentive management is again behavioral treatments of CBT. It's like a talking therapy. Patients vary in their response to attention diversion strategies, and there are individual differences in what diversion techniques are effective as a method of pain relief. The core concept of attention diversion is to divert attention from the pain by refocusing or directing attention to something that. So again, this is also relates to gate control, that you try to physiologically divert your attention. Sorry, psychologically divert your attention, which makes you not focus on pain, but rather on something else that you try to focus on. You just alternate, you just trying to substitute that I'm going to be focused on this. So that an example of this is that when your therapist basically tells you that go to your happy place, think of your happy place, think of your family, you having good time with your family. Now that is basically diverting your attention to something that is more positive, rather than you having to focus on pain, because the more you focus on it, the more you recognize it, and the more you recognize it, the more it hurts. Then you have imagery. So deliberately using imagery, so a form of attention diversion is imagery. So that's the example that I gave you, that you actually think of things that you might enjoy, think of things that might help you, or think of things that make you happy, and that is basically attention diversion, but in the form of imagery. You have Morley, Shapiro, and Biggs developing a training program in which they taught patients how to use attention diversion strategies such as use of imagery and mindfulness. So that is basically creating a vivid image and creating a pleasant image in your mind, thinking of a more pleasant environment in your head. The other one that they taught is basic attention management. So basically relaxing and teaching yourself how to be relaxed in a very pressurized situation. And then pain coping strategies, so that is basically coping statements or signal breathing. So deep breaths and coping statements that you can do this, you've got this, something that we do with yoga. Another thing was that they could discuss the pain and the relationship in pain in order to understand it, and just generally share it, and treat it in that way. Attention diversion and mindfulness, so that would mean focus on details of experience, mindfulness breathing exercises, integrating mindfulness in everyday activities. So that is basically diverting your attention in a very positive way, focusing on positive stuff, being mindful, being thoughtful, okay, and thinking about yourself, thinking, prioritizing yourself. It's very something that sounds motivational. Intense pain and flare up, so identifying responses to pain and vicious cycles in thoughts, images, and behavior, diffusing catastrophing, and breaking vicious cycles. So trying to stop anything that is becoming a vicious cycle. It's like something that is constantly hurting you, constantly causing you pain. If you're doing a certain thing and that's constantly causing you pain, then stopping that thing, or managing that certain thing. So if you're constantly walking on rocks and that is hurting you, then stopping that thing. Just a very general example of breaking vicious cycles, that they basically suggested all of these ways in order to manage pain. And pain transformation images, so creating images to transform pain. In the first period, until the 3 months follow up, pain intensity reduced. So until 3 months, pain intensity was reducing, and it was maintained at a 6 month follow up. Participants reported that they were using brief relaxation, they were using imagery, they were using distraction, and their attitudes in pain and their stress and their sleeping patterns, all of these things were better now. They were doing better just because they used all of these things, where they used imagery, where they used mindfulness, where they alternated between feelings. They focused on the more positive coping statements rather than focusing on pain as a whole. Is that clear?
Yeah.
One thing that you need to know over here, this is something that will work more with chronic pain rather than acute pain, because this is something that you will work on with the in the long term. Looking at acupuncture, you can study about this on Google as well. Acupuncture is a Chinese medicine where they actually pin you with needles, okay, and then they basically just to this is done to A, relax you, okay, and B, just to stimulate your nerves, so making your nerves work. And when your nerves work, that generally relaxes you and generally starts healing. So obviously, when your body is working faster, it actually results in more healing processes. Hence, acupuncture is just, it is a very proper medical thing, and it actually works. And a cupping is also a part of acupuncture only, but it's just basically you poke the skin, you have these needles in the skin which basically relax you, and at the same time it actually leads to a quicker healing, session. They're saying that in the next page, this results in body producing pain relieving substances such as endorphins. So everything that because you are poking your body with needles, that releases some of the negative chemicals as well. It is likely that these substances are responsible for any beneficial effects seen with the type of acupuncture. Traditional acupuncture is based on belief that an energy or life force flows through the body channels called meridians. So this is a very traditional belief. This is something very superficial. However, they have actually turned it into a very biological thing now. Then they've given an example of another technique, which is a TENS machine, which is basically another method of relieving pain through electrical cords. Okay, so it has a small battery, and you basically give electric impulses to your veins, and that leads to again relaxation of the muscles. It is this tingling feeling, and when your muscles are relaxed, obviously your body starts healing better. And that's literally it. That's all you need to know about all of these two treatments. Even though they've made it seem like it's complicated, it's not. It's just generally you need to avoid painkillers, and in order to avoid painkillers, the one thing that you need is to relax your body so that it can heal. And the way you can do that is either through acupuncture or this TENS machine, which is acupuncture is basically poking your body and releasing all the negative energy in some sense or the other. And when you're talking about TENS, that is giving mild electric shocks to your body, so that actually activates your nerves, and again healing process begins faster. Is that clear?
Yeah.
Okay, do you have any questions at all, or something that had been annoying you with pain?
No.
Okay, so we are gonna do stress tomorrow then.
Okay.
So tomorrow we have class from 3 to 5. Okay, so 3 to 5 means that 1 hour we're going to devote that to sociology, and 1 hour we're going to devote to psychology. Okay?
Yes, miss.
Perfect. I'll see you tomorrow, inshallah. Thank you so much.
Okay, thank you, miss.